Dear audience, this talk is going to be about a new look at the corticosteroid story. And you'll notice that what you see is not always what you get. I have no disclosures to make, only formal governmental research grants. Cortisol is vital for the fight or flight response. The brain senses a stressor that activates CRH to activate the pituitary to release ACTH, that activates the adrenal cortex to synthesize and release cortisol, exerting feedback inhibition at the two levels. No less so for critical care patients, where it plays a role to control inflammation, to provide essential metabolic substrates, to retain fluid in the circulation, and to increase cardiac output and blood pressure, to name just a few. Can this vital system fail? Yes, it can. And this is just basic endocrinology. And I will refer to the endocrine definition of adrenal failure by calling it absolute adrenal failure. And there are three types of absolute adrenal failure. The primary adrenal failure, when the adrenal gland is failing, and two central ones, secondary adrenal failure when the pituitary is failing, and tertiary adrenal failure when the hypothalamus is failing. All three conditions are characterized by low plasma cortisol, whereas the two central ones have low plasma ACTH, and the peripheral adrenal failure has high ACTH. In the context of critical illness, it was suggested that this system could partially fail, being that it is activated but not enough. And that concept was first launched by Gilali Anane in 2000. He called for the first time this problem relative adrenal failure, occurring in patients with septic shock, being an adrenal cortex that's maximally stimulated but not enough to survive. His study claimed that this condition can be diagnosed by a synactin test, 250 micrograms of ACTH, synthetic ACTH, that is. When that would generate a cortisol incremental response below 9, that would indicate that this relative adrenal failure would be present. And this irrespective of the plasma levels of cortisol that could be high, normal, or low. If this condition would really exist, what you would expect is a very high plasma ACTH concentration, but these data were never mentioned into this concept. We started to doubt whether this really reflects a failure of the HPA axis. What you see is not always what you get. And the reason why we doubted it is because in our studies, and others also have shown it, actually patients in the ICU do not have high ACTH levels. In the first week, as you can see here on the bottom, plasma ACTH levels are always low, and these patients have high cortisol levels. So difficult to believe that the high cortisol is actually driven by ACTH. And with state-of-the-art tracer studies, we had shown that the production rate of cortisol during the day in ICU patients was either normal when patients had no SIRS, or just doubled when patients had SIRS, but never the assumed 6 to 10-fold increase that would be necessary to get these high cortisol levels if everything else would be normal. And during the night, we had shown that ACTH-driven cortisol pulsatile secretion was actually lower in patients than in healthy subjects. What we did find also with using state-of-the-art tracer technology is that the breakdown of cortisol, the metabolism of cortisol, was suppressed in all patients. This due to suppressed activity and expression of the cortisol metabolizing enzymes in liver and kidney. And because the breakdown of plasma cortisol was suppressed, when you inject a bolus of 100 milligrams of hydrocortisone in patients, what you see is that the half-life is dramatically longer as compared to the healthy controls, up to 8-fold longer. So the cortisol is not cleared, and that is why plasma cortisol is high. Not only because of the cortisol clearance, actually there is a second mechanism that increases the free availability of cortisol, and that is the reduced expression and availability of the cortisol plasma binding proteins. Low CBG levels are due to downregulation of the glucocorticoid receptor in the liver upon ligand binding, as we have recently shown. So it's an acute stress response, CBG goes down. This together with the reduced binding affinity for cortisol dramatically increases the free cortisol availability. So in critical illness, systemic cortisol availability is high. This is due to reduced plasma binding and to suppressed cortisol breakdown, not due to increased ACTH-driven cortisol production. What happens beyond the first week in ICU? We were interested because that could actually lead to some endocrine problems. The first week, I already showed you the data. ACTH is low, maybe creeping up a little bit by the 7th day. Cortisol is high. And then we did a study where we specifically investigated patients who were in the ICU longer, 1 to 2 weeks, 2 to 3 weeks, 3 to 4 weeks, and beyond 4 weeks. And I'm going to show you the hormonal levels and also the results of weekly synactin tests to see what happens in the more chronic phase. Here you see that patients in the ICU, no matter how long they stay, always have lowish ACTH levels that come up a little bit with time but are never high. 1 week after they were discharged to a regular ward and when the patients were recovered, we also did a measurement, and what you can see is that only then patients have high plasma ACTH. Cortisol, total cortisol, high, coming down beyond the 4th week. But again, when patients were discharged to the ward, then plasma cortisol was high. Free cortisol, the same thing. Increased, coming down with time, no longer elevated in the really long stairs, but look what happens on the regular ward 1 week later. Then they have high plasma cortisol levels, total and free, and high ACTH levels. Not during their critical care phase, but thereafter. These are the responses to the weekly synactin test, and we were really surprised to see these results because all patients in the ICU have low incremental cortisol responses to synactin, all of them. Do they all have failing adrenal glands, we thought? Probably not, because look at the free incremental cortisol response. This is always normal, and in some patients even high, and this throughout their phase in the ICU. So we were a bit puzzled about that initially, but actually the data from this slide that I showed you earlier already holds some information to say why these incremental cortisol responses to synactin are always low. It is because the distribution volume of cortisol is much larger in the ICU patients. This is the data from the 100 milligram of hydrocortisone, and you see that the peak in the plasma after the same dose is much lower in patients than in healthy subjects. The distribution volume of cortisol is much larger, and this is fully explained or entirely explained by the low levels of CBG. As you can see here, they're always low, and this is why the synactin responses are low. It has nothing to do with the adrenal reserve. Indeed, if the distribution volume is so much larger, the same amount of cortisol in response to synactin may just be diluted into a larger volume and therefore give you the impression that the adrenal gland is failing, but that's not the case. Cortisol breakdown is reduced throughout the ICU phase as shown in this slide. So that is a very robust finding. Now, why is ACTH not increased? There are 3 possibilities. Either the pituitary is damaged, the hypothalamus is damaged, or it's negative feedback inhibition. And we actually try to differentiate between these 3 possibilities by doing a CRH stimulation test, where we looked at the plasma ACTH responses. If the hypothalamus is damaged, this ACTH response is delayed and increased. If the pituitary is damaged, the ACTH response should be acutely suppressed. And if it's feedback inhibition, ACTH response should be normal in the acute phase, but suppressed in the chronic phase. We did a study where we looked at these 3 phases in patients in the ICU who were nicely matched also with healthy control subjects. And these are the results. It is clear that the ACTH response to a CRA bolus is only reduced in the subacute and the chronic phase, not in the acute phase. And this is compatible with feedback inhibition, just physiological feedback inhibition or suppression by other ligands. Just briefly, data on children. Actually, the phenotype in children is even more pronounced than in the adults, and I'm not going to go into details for sake of time. And here we address the question whether these changes in ACTH and cortisol are good or bad. First of all, what we found was adjusted for risk factors, treatment with steroids in ICU children was negatively associated with outcome, and also high free cortisol levels and low plasma ACTH levels were associated with poor outcome, meaning that high ACTH may be protective and high cortisol may not be beneficial. Why would low ACTH be bad? Well, because ACTH is a very important trophic factor for the adrenal cortex, and we have data to show that this actually, at least in postmortem studies in ICU patients, that there is signs of atrophy in the long stay patients, not in the short stayers. So in summary, what you see is not always what you get. I'm summarizing the data. All acute critically ill patients have high free cortisol availability due to low cortisol binding proteins and suppressed cortisol breakdown, not due to increased cortisol production. All acute critically ill patients have normal or low plasma ACTH, likely explained by feedback inhibition due to high free cortisol. All critically ill patients have low incremental cortisol responses to a synactin test, but this is due to an increased cortisol distribution volume, and which makes this test not suitable to diagnose adrenal failure. It doesn't say anything about the adrenal reserve. In prolonged critically ill patients, suppressed ACTH was found, at least in children, to be independently associated with poor outcome. Therefore, specifically prolonged critically ill patients may suffer from central adrenal insufficiency due to sustained suppression of ACTH and hereby lack of ACTH trophic effects on the adrenal cortex. This is a very important finding, should be further explored. First of all, why? What is the exact mechanism suppressing ACTH? And second, what is the implication clinically, and should something be done about that? These are the important new insights, and I'm referring you to a review paper that we've recently written and that summarizes those new insights and clearly elaborates on the 3 phases of the HPA axis stress response to critical illness. And with that, I thank you for your attention.